Okay, hi, this is Elliot Fishman, and let's go back to part 2 in the evaluation of suspected small bowel obstruction. In this article by Paulson, it's an excellent article, Paulson and Thompson, let me give Bill credit as well. Small bowel obstruction continues to be a substantial cause of morbidity and mortality, accounting for 12 to 16% of hospital admissions for evaluation of acute abdominal pain in the U.S. Most patients with SBO are treated successfully with NG tube decompression. However, the mortality of SBO ranges from 2 to 8% and may increase to up to 25% if ischemia is present. So that's the problem with small bowel obstruction. Most patients can be treated conservatively, but the patients who need surgery, if you don't do surgery, the morbidity increases by at least threefold just in the first 24 hours. And surgeons are very aware of that, as we all are, so you would hate to make a mistake of not operating on the right patient. Paulson makes the point that multi-detector CT is the best imaging tool for evaluating suspected SBO with sensitivity and specificity of 95%, as well as highly accurate in detecting complications of SBO. Now, if you ask me what are the causes of bowel obstruction, it's too numerous to list, and I tried to list them and fill as many things as I can put on one slide. From extrinsic, the common adhesions, we'll look at hernias, both internal and external hernias, things like endometriosis with implants or tumors that involve the bowel secondarily, like a retroperitoneal sarcoma. We talk about inflammatory or infectious disease. We talk about small bowel tumors, both primary as well as metastatic. We talk about ischemia. We talk about hematoma. We talk about things related to therapy, including radiation enteritis. And we also talk about things related to chemotherapy. We talk about intussusceptions, which usually are tumors, most commonly small, but can be malignant tumors. But intussusceptions can be caused by things like hyperplasia of the bowel wall. We could talk about different infectious or inflammatory etiologies that can cause intussusception. We also talk about things like gallstone ileus, bezoars, and foreign bodies are all possibilities as well. If you look at big numbers, adhesions rules the way, 75%, external hernias 10%, and neoplasm about 5%. The problem with adhesions, of course, as we know, is you can see the transition point. Often it's hard to see the adhesion because it could be as thin as like a piano wire. So you kind of can say, okay, I don't see a mass, I don't see an internal hernia, but I see the transition point. And then as you look hard with multiplanar, perhaps you can suggest the possibility of adhesion, but sometimes you kind of know it's probably an adhesion, and you can say that in the report, but you don't absolutely see it. So when you think about small bowel obstruction, what are we telling the referring clinician? Does the patient have an SBO, or the patient's symptoms, abdominal pain, whatever the symptoms are, related to another cause? Maybe it's pancreatitis, maybe it's diverticulitis, maybe it's Crohn's disease. And then we need to say is that if the patient has a small bowel obstruction, is it partial or complete obstruction? What needs to be done? Can the patient be managed conservatively, or is it go to surgery? If the patient does have an SBO, can we determine its cause? And again, the importance of management. So much of what we do in CT, and this is going to be true as AI comes along. I think what AI is probably going to do is help us predict how we should manage patients based on a set of symptoms, clinical as well as imaging symptoms, putting it all together and making decisions. But that's the biggest decision. Watch the patient or take the patient to surgery. Time to surgery is the most important prognostic factor, as mortality significantly increases with the duration of symptoms. In an article by Ritz, the survival rate first 12 hours, 84%, compared with only 11.6% after 24 hours and 2% after 48 hours. Remember, all surgery residents, they still probably are, but they were always taught that the sun never sets on bowel obstruction. If the patient has bowel obstruction, the patient needs to go to the operating room. That will have the patient's outcome be substantially better. Simply saying, let's follow and see what happens tomorrow, is not a good strategy. Now, if you look at small bowel disease CT findings, we talk about wall thickening above 3 millimeters being abnormal, which means to me if I can measure the bowel, it's abnormal. We talk about enhancement being abnormal, increased enhancement or decreased enhancement. With ischemia, early you may see increased enhancement, and late you may see decreased enhancement. Position of bowel. Is the bowel in the abdominal cavity? Is it where it's supposed to be? Or is it a hernia, external or internal hernia? Is there malrotation? Look at the vessels carefully. What about the mesenteric fat? The mesenteric fat is a good sign of local inflammation that can be very helpful. Do we see anything in the mesenteric fat like small nodes, inflammatory changes, prominent vascularity, or is the mesenteric fat perfectly normal? In terms of dilated loops above 2.5, some people would say 3, but 2.5 is a number we like. We look for a small bowel feces sign, which is easier to show than to describe. It's air bubbles and intestinal content proximal to the site of SBO. Now, yes, you can get a small bowel feces sign in a patient with malabsorption syndrome, a patient with cystic fibrosis, but usually it's a really good sign showing you where the transition point is. We look for bowel wall thickening and then, of course, looking at transitions. Dilated versus collapsed bowel. Where is the transition and why is there a transition are things we, of course, need to answer. In this article, high-grade and chronic obstructions, endoluminal stasis or gas creates an appearance rather similar to feces and colon, the small bowel feces sign, prevalence between 6 and 37%. The feature is usually evident just proximal to the transition and can help localize it. However, it has a poor correlation in patients requiring surgery approach or not. So I like the feces sign. When it's there, it's very helpful, pinpointing where the transition is, and then you go from there. But it's not always going to be there. Here's just a great example. Dilated small bowel, wall enhancement. You follow it down, it's kind of layering out. That's why the coronals are so good. Then you reach the lower loop, and you see it looks like stool, right? It looks like feces. This is small bowel. Transitions right here. This was an adhesion causing obstruction. Patient went to surgery. The adhesion was like a piano wire, just simply positioned really well. And because of that, you cut the adhesion and the patient's bowel was great. The patient did fine. Just a really nice example of showing you all the findings. Dilated small bowel, the importance of coronal views, the transition point, and the feces sign very nicely shown, be it on the routine axials, routine coronals, but especially on the volume rendering and the MIP imaging here. And again, we get the transition point. Now you can look and say, am I sure that's an adhesion? Well, I don't see a tumor. I don't see an internal hernia. I know exactly where the obstruction is, but I don't see a mass. In that case, I would dictate that I don't see a mass, I don't see a hernia, I don't see anything else. And based on the sharp margins, it's likely in this patient who had an appendectomy 20 years earlier that this is due to adhesions. So again, a very important sign. Now, the small bowel feces sign, when I went back to signs and imaging, this was way, way back, 2002. Just a really nice example showing you the small bowel feces sign. It is defined by the presence of particulate, feculent matter mingled with air bubbles in the lumen of dilated loops of small bowel. It's the result of delayed intestinal transit and believed to be caused by incompletely digested food, bacterial overgrowth, or increased water absorption of the distal small bowel proximal to the obstruction. And again, very important, bowel obstruction accounts for approximately 20% of acute abdominal surgical interventions. In 60 to 80% of intestinal obstruction, it's the small bowel involved. But again, remember, this sign is very helpful. It's not always specific, and it occurs in no more than 1/3 of patients with bowel obstruction in the best of hands. In this other article by Scaglione we referred to before, the most common cause of closed loop obstruction is a single adhesive band, and the incidence is high in patients with Roux-en-Y bypasses or simply previous laparotomies for any other reason. It's kind of interesting. Those of you who've been around for a while remember when laparoscopic surgery, which is indeed a miracle. Patients get an appendectomy laparoscopically and they're discharged the same day. So much oncology surgery, including pancreas, is done with laparoscopic surgery. So laparoscopic surgery is one of the medical miracles. But it's interesting, one of the things that was said initially with laparoscopic surgery, you don't get adhesions. Well, we do know you do, and sometimes because of multiple trocars, you get more adhesions than an open procedure. But again, whether a patient's had open or laparoscopic surgery, the chances are similar for having adhesions. Now, when we talk about volvulus and internal hernia, what are we looking at? The first thing we look at is dilated loops of bowel, like here with wall thickening. There's also some ascites present. When I see dilated loops of bowel plus ascites, I'm always thinking about ischemia. You also notice that the dilated loops, at least on these two images, are on the left side only. The other images have some contrast and are not dilated. And then when you follow it downward, you realize that all of the dilated loops are in the left upper quadrant. And here's a bowel loop, and here's a twist. You see the twist here? You have multiple dilated loops of bowel with wall thickening and decreased enhancement, inflammation around the bowel loops, and you can see that internal hernia. Classic volvulus appearance, nicely shown on the coronal images. This is a surgical emergency. This patient will develop infarcted bowel if there's no intervention. Again, look at the images. Here's a few more. The fold thickening of the bowel, the dilated bowel, the thickening, and the lack of enhancement of the bowel, and the presence of ascites. To me, when you're looking at ischemic bowel and you see abnormal bowel loops, whenever I see fluid, I'm always thinking there's ischemia present. And I'll talk about that also when we see hernias like incisional hernias or inguinal hernias. It's one thing to see the bowel loop, you look for dilatation, but when I start seeing a little bit of ascites present, I'm always worried about ischemia. In this article, bowel wall thinning is a common feature of arterial ischemia. The bowel wall can become markedly paper thin or severely thin. These findings result from loss of arterial supply to the bowel wall mucosa, which can progress to transmural infarction and, in cases, perforation. Another example, when you look at these two images, you see a very nice arterial injection. Look at the patient's iliac vessels. But you notice these loops, not only are they dilated, but they really aren't enhancing well. Where's the wall? There's lack of enhancement. On arterial phase imaging, you should see reasonably good enhancement. And then as you follow this downward, look at our look. Now you see, here's the mesenteric vessels. SMA, the vessels look twisted and small. You see the haziness in the mesentery. You see the haziness around the vessels, and the vessels are all really tiny. That's because there's a twist. There's a volvulus present. This loop is not enhancing. Even when you put it on the MIP imaging, you see minimal enhancement. And so you're dealing with abnormally looking SMA. It looks like the SMA is twisted. Then you see the small bowel is dilated. There's haziness of the mesentery. The vasa recta to the mesentery are very tiny and poorly visualized, and you see local inflammation. Beautifully shown also on the cinematic rendering, which accentuates the bowel that's ischemic as opposed to the normal bowel. Again, that's one of the really good things about cinematic rendering. And you see also the twisting of the vessel and the very fine appearance of the vessel. These are just too small, and they're twisted and they're irregular. This is ischemic bowel with a closed loop obstruction. Now, closed loop obstructions are surgical emergencies. They can be caused typically by adhesive bands, or they can be due to an internal or even external hernia. Closed loop obstruction can lead to a volvulus, which leads to impairment of venous outflow, followed by arterial ischemia. And that, of course, explains why you see a lack typically of bowel enhancement. With closed loop obstructions, you have a C or U-shaped distended loops with the mesenteric vessels converging toward the site of obstruction. The site of obstruction is usually clear on CT, particularly when you do MPR or 3D imaging. Paulson makes the point that the CT findings of a closed loop obstruction depend in part on the orientation of the loop relative to the plane of imaging. And that explains why, this coffee bean appearance, why looking at coronals and sagittals and axials, why you need everything in order to make the right diagnosis. Now, sometimes we also recognize the bowels in the wrong place. Here you're looking at the lesser sac. There's nothing in the lesser sac, right? You go to the pancreas from the stomach, but here you see in the lesser sac multiple loops of dilated small bowel, which are also enhancing poorly. And if you look at it, and again, we talk about interactively looking at the images. If you look at the images as we go down, you'll see that there's multiple loops of bowel sitting in the lesser sac. There's the haziness of the vasa recta. Small nodes are present. You look distally, you have normal bowel enhancement, but when you go back proximally, you see that the bowel loops really are not enhancing. That's an internal hernia with a closed loop obstruction. And again, it's easier to see at times on the coronal view, though I thought it showed very nicely there axially. But look at the loops of bowel here. Lack of enhancement, stretching of the mesenteric vessels. If I go back just a little bit, you see how the vessels are stretched. They're also not as sharply defined as we typically see them. And then, of course, as we go through the data set, you get a feel of that interactivity and how we can see the abnormal loops, where they are, and how they're sitting in that internal hernia. Again, you want to look at it a third time. Here it is very nicely looking at the sagittal view, and you can see the bowel loops really sitting nicely in the patient's lesser sac, pushing right against the celiac and the SMA. And here it is, just two snapshots. Again, lack of bowel enhancement, dilatation, but also the vasa recta show a haziness and then not as bright as it should be because you have lack of flow. And that's that twisting phenomena. So you have lack of flow, and this is why this bowel will be infarcted, and that's why the patient's a surgical emergency. You can see distally the small bowel looks okay, but it's pulled upward, and there's the large bowel sitting a little bit more to the right than usual. And again, here's that same look at the vasa recta with the volume rendered images, very nicely shown on these images and even on the simple coronal views. Another patient with acute abdomen, again, you see lots of dilated bowel loops. They don't have the enhancement of the normal loops here. So what's going on? There's also this haziness. You're looking down into the pelvis. We see ascites. Remember, I commented before, if I see ascites and I'm worried about ischemic bowel, I'm always worried even more because ascites is always a bad sign to me. And here you can see on the coronal views and the volume rendered views and the MIP imaging, the twisting of the vessels, the small branching off the SMA, the dilated loops of bowel, this kind of twist centrally, the edematous changes, and the ascites. Putting that all together, the patient, again, has his midgut volvulus with ischemic bowel, and again, a surgical emergency. The lack of enhancement of bowel, the twisting of the vessels, the ascites. This patient had a long segment of bowel resected at surgery, but managed to survive. So this was, interestingly, it was an internal hernia due to adhesions from the cecum to the right ovary. So with adhesions, there are many reasons we said for adhesions, and often you can see the adhesions. Here we knew there was an internal hernia with obstruction. It was at surgery that you knew specifically what the cause was, but patient went to surgery. Now, in this case, small bowel obstruction due to closed loop with a U configuration. Many people talk about this U configurations. Well, what do I see here? There's dilated bowel with a feces sign, right? I see the feces sign. There's a little bit of fluid here that worries me, right there. Then I track downward and look at this beautiful U shape, right? You can tell that the patient has a twist. This bowel has a feces sign. It's obstructed. This is a surgical emergency, explains the patient's right lower quadrant pain, which was thought to be appendicitis perhaps. And here's a very nice look with a drawing showing the decompressed distal bowel, the dilated proximal bowel, and the closed loop with an adhesion along the opening. Just a really nice correlation. Here it is again on the volume rendered images. So a very important concept. Bowel obstruction when two adjacent sites are obstructed, separating the obstructed loop from the remainder of the GI tract. And this is where you talk about that coffee bean configuration, or in the last case, these are surgical emergencies. This is this twist. The closed loop may twist along its major axis and a volvulus. That is bowel torsion on its own axis may occur, and the last two cases were really nice examples of that. Let me show you one more case and then we'll take a break. Patient with abdominal pain, and you see clot in the patient's left atrial appendage, very nicely shown there. And then you scan downward and you say, well, I see the SMA, but wait, there's clot in the SMA right here. The bowel proximally is not dilated, but there's occlusion of the SMA. Importance of sagittal views to look at the celiac and SMA and IMA, very nicely showing you the occlusion, which will lead to ischemic bowel. When you look at it with MIP imaging, you see the occlusion very nicely. Here it is on the venous, where you see the occlusion of the SMA. SMV is patent, and now you see the distal loops are dilated. You can see there's some pneumatosis present in the bowel, but now I have dilated loops of bowel with pneumatosis. We see a transition point, and I see the presence of occlusion of the SMA. So I know we're dealing with ischemic bowel. They will try to go in, remove that clot. If they go in early enough and the patient's lucky enough, the patient can get the clot removed and no bowel resected. Again, to make the point, you got to look carefully at the vessels. Here it is, it's somewhat subtle, but not that subtle, right? There's the SMA, there's the clot again. But if you don't look carefully, often people will look at the proximal aspect of the SMA, it looks great, and they won't follow the SMA or the SMV all the way, or the celiac all the way downward. You have to do that. So a beautiful example of atrial thrombus with embolization with clot in the SMA and ischemic jejunum. Just a really nice case. And here's another case, and right lower quadrant pain, dilated small bowel loops. That's easy. We keep tracking this downward. We see the bowel enhancement, but you see this big tubular structure, right lower quadrant. Here it is really nicely shown. This is where the ileocecal valve is. So you can see this loop here, and if I go back, the loop is really distended and it's kind of twisted. There's inflammation in the right lower quadrant. The vessels are all stretched. Vessels are small. And if you look at it, again, we'll just look at it interactively, and you see as you look into the aspect of the vessels, we'll want to look at the SMA, we want to look at the celiac, we want to try to follow the bowel loops downward, and that becomes very important because you can see the dilatation, then you can see the twisting. Look at the right lower quadrant, that adhesion where things have flipped. Look how small the mesenteric vessels are. Just a beautiful example showing you these findings. And here it is again on the other set of images. Again, the ability to look carefully at the mesenteric vessels, the occlusion of the SMA, and the involvement of the bowel. So just a really nice example. And in this case, what you had was a cecal volvulus with obstruction of the distal small bowel, explained by that twist in the right lower quadrant. And again, here's a very nice schematic of that. Excellent drawing by Frank Curl. He used to work with us, now is at Mayo. Now, hopefully we'll discuss this. I have a specific talk I'm developing on internal hernias and talking about intussusceptions and volvulus, and try to cover all of those in one talk. Volvulus is often easy to diagnose, but sometimes it's hard if you're not thinking about it, so we'll think about it. Now, other things that cause obstruction are, of course, hernias. I showed you a really nice example of a hernia into the lesser sac. But hernias, as a result of surgery like laparoscopic surgery or other surgeries, are all possibilities. So let's do this. Let's stop here and come back, and let's talk about hernias and the range of hernias we see on CT causing small bowel obstruction. See you in a few minutes. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.